Many thanks to PK and the rest of the organizing committee for the invitation to present at the New York Endovascular Summit. My name is Stephen from Singapore, and I'd now like to deliver my talk on transcatheter arterialization of the deep veins, results and how I do it. My disclosures. The problem in critical limb ischemia was elegantly described by Roberto Ferrezi in his landmark paper. Firstly, there was a problem of transmission failure due to big artery disease. Second was that of a distribution failure due to small artery disease or arteries in the plantar arch, metatarsal or digital vessels. This commonly gave a scenario of a no outflow on angiogram, or what we term the desert foot. Surgical venous arterialization was used as a method to revascularize patients with no option CLI. Since 2012, we embarked on a percutaneous program, and several cases have been done worldwide. Over the years, the procedure has evolved, but so has the name. I would now like to propose a new name called transcatheter arterialization of the deep veins, or TADV for short. Now, the lymph flow system has an arterial catheter, a venous catheter, a forward-cutting valvulotome, and several self-expanding stents, one of which is tapered. The Gen 2 lymph flow device has an arterial catheter that's 6 French compatible that allows us to penetrate deeper tibial vessels. The 10 mm enhanced needle allows us to hit calcium crossing from an artery into the vein. The venous catheter is no longer ultrasound dependent. It is now a self-expanding nylon mesh that allows the snaring of the wire. The V-Seaver catheter is also 4 French compatible, allowing distal pedal access. Stent graft system is still 7 French compatible, but now has self-expanding stents extending up to 200 mm. This, in combination, has allowed an 82% reduction in crossing time observed between the first and second generations. I'd now like to show you a case that was done recently. This is an elderly gentleman with diabetes and hypertension with a high-risk Wi-Fi classification. After failed intervention, he was put up for deep venous arterialization. As seen in the angiogram, the peroneal artery is the only single vessel runoff to the foot with a desert foot scenario as seen. With failed prior intervention, this represents no option critical limb ischemia for us. With a 4 French catheter, the posterior tibial artery was recanalized with a CTO wire, pre-dilated with a balloon over a supporting wire, Distal venous access was acquired using an ultrasound guidance and using only the dilator of a micropuncture sheath. A diagnostic venogram was done, and double injection venogram revealed the close distance between the artery and the vein. The 7 French arterial catheter was pushed deep into the posterior tibial vein, and the crossing was performed very easily with a single puncture from the artery into the vein. After snaring of the wire, the micropuncture was used to generate a roadmap for us to cross the valves into the lateral plantar vein with an O14 wire. After traversing a normal plantar venous arch with an O14 wire and a 2.6 French CXI catheter, this was exchanged out for an O18 command. The 4 French cutting valvulotome was used to lyse the valves in the deep plantar veins of the foot. Balloon dilatation was subsequently performed. Due to the severe recoil of the veins, a decision was made to extend these stents with a self-expanding drug-eluting stent, or the Illuvia stent, in the plantar aspect of the foot. A tapered stent was placed in the crossing point, and these are the finding angiograms. At the same time, the great saphenous vein was surgically ligated. Summary of what was done for the patient from an initial desert foot scenario with a low TCPO2 This patient underwent a lymph flow procedure with simultaneous great saphenous vein ligation. 1 month later, he underwent a medial marginal vein coiling to focalize the blood. With serial angiograms at 2.5 and 5 months, one can see the maturation of the distal vessel circulation with increased contrast flow into the distal vasculature, and this commensurated with an increase in TCPO2 to very impressive levels of 65 and 72 at 5 months and complete wound healing. A patient with diabetes, hypertension, and ischemic heart disease with end-stage renal failure on dialysis with a high-risk Wi-Fi. Again, with the initial desert foot scenario, a deep venous arterialization with a lymph flow procedure was performed. At 1 month, coiling was performed of the outflow veins, and similarly more coiling was performed at 2 months. One can continue to see a change in the distal vasculature with increased perfusion in the small capillary systems of the foot. An angiogram at 4 months, one can actually see the increase in blush seen on the AP foot angiogram, together with the rise in TCPO2 and again impressive TCPO2 numbers of 64 and 57, and finally wound healing without the need for a transmetatarsal amputation at 7 months. Another patient with infection and critical limb ischemia. On a lateral foot x-ray, this patient has a moderate or severe medial artery calcification score, or the MAC score, and type 1 no option critical limb ischemia with the presence of infection. Another patient with no option critical limb ischemia with desert foot had a lymph flow procedure done to the lateral plantar vein. This was supplemented on day 40 with embolization of the medial marginal vein to focalize the blood. We continue to see a rise in TCPO2 to an impressive level of 79 at about 180 days. Clinical progress was impressive with wound healing of the first metatarsal amputation site with no further amputation of the toes. And finally, one of our more severe cases, an 83-year-old gentleman with diabetes, hypertension, ischemic heart disease, high-risk Wi-Fi status with a failed retrograde intervention in another hospital. On clinical examination, the midfoot joints were exposed, and an angiogram inflow disease of the SFA of common femoral artery was treated, and balloon angioplasty of the posterior tibial artery was performed with high-pressure non-compliant balloons. However, the outflow through the medial plantar artery was insufficient to allow wound healing. After optimization of the common femoral and superficial femoral artery with stents, the wound did not heal. Several months after that, we subjected this patient with a severe midfoot wound infection to a lymph flow procedure to the medial plantar vein. Immediately, we could appreciate the improvement of the foot with granulation across the midfoot joints with negative pressure therapy. 9 months after the lymph flow procedure, minor re-intervention was performed, and finally a transmetatarsal amputation and finally wound healing was possible 1 year after the initial procedure. Summary of the results of studies performed on percutaneous deep venous arterialization. After the first immense study with 7 patients, 32 patient registry was performed, or called the ALPS registry. The PROMISE 1 early feasibility study in US had 32 patients with an independent adjudication of a no option critical limb ischemia. The PROMISE 2 study was recently completed, and the results will be announced in Viva this year. Several other off-the-shelf studies, including the DEPARTURE study in Japan with complex patients with a high number of patients with dialysis, as well as an experience from Fadi and Jihad with 42 patients. One can see very respectable amputation-free survival at 6 and 12 months, as well as limb salvage rates. Complete wound healing was also very reasonable in these patients otherwise destined for amputation. In summary, transcatheter arterialization of deep vein is a viable and real solution for no-option critical limb ischemia. The lymph flow device is a purpose-built device allowing standardized reproducible procedure to be performed in first-time implanters with a high rate of technical success. Studies have shown good amputation-free survival, limb salvage, and decent wound healing in complex patients destined for limb loss. Promise 2 US pivotal trial will be announced in Viva 2022. The TED-V should strongly be considered as a first-line therapy for the desert foot or SAD disease before futile below-the-ankle therapy. Thank you very much for your attention.